cardiovascular pathology, ischemic heart disease manifestations. All right, so this page is relatively high yield. We have to fully understand what's going on with the pathology of the heart when it's under stress of ischemia, okay? And first and foremost, we have to kind of define ischemia and what that means to us. We already went over it in pathology, but to fully understand what ischemia is, just the overview is that when our O2 supply is less than our O2 demand. Okay, so if our heart has a specific O2 demand and our blood is not reaching that O2 demand, it's not supplying that much O2 that's needed. Okay, so that's all that ischemia is. It's just when you don't have enough oxygen. Okay, so the first thing that occurs and what we have to really first understand is that angina is the number one manifestation that we're going to be seeing associated with ischemic heart disease. Okay, and all that this is just chest pain. Okay. And it's secondary to the ischemic myocardium, right? And that could be due to multiple issues, could be due to coronary artery narrowing, right? So if we have a narrowing of the coronary artery, we don't have enough blood supply to the area, hence not enough oxygen supply. And there we go. We have ischemia, and that can lead to angina. Or we could have vasospasm of those arteries as well. And then that leads to a decrease in blood supply, decrease in oxygen delivery, leading to an overall chest pain due to angina. Okay, so that's what's occurring. We have ischemia that can lead to the first presentation of angina, and angina is just chest pain. There's no necrosis, nothing's really occurred yet, but there's different types that we need to go over. The first type of angina is stable angina. Now, what stable angina is defined by a 70% occlusion, okay, secondary to atherosclerosis. Okay, so if we have atherosclerotic plaques and there's a 60% occlusion, nothing's going to happen. You're not going to have any symptoms. There's nothing that occurs. The number that they like to use, okay, now it's rough estimate, but the number that they like to use is 70% occlusion. If there's a 70% or greater occlusion, then you will start to have stable angina. And what does that mean to us? Stable angina, all that it is that there is pain, okay, you have chest pain, angina, on exertion, okay? Now, once you relax, that chest pain goes away, okay? So very important to understand that. Is there any troponin levels? No. So there's no leakage of, and troponin, all it is a protein found in cardiac muscle. And the reason we measure troponin is because if we have death of cardiac cells, then we're going to be able to see large number of protein in that blood, cardiac proteins in the blood known as troponin, right? Because they start to lyse, the cells start to lyse and release this protein. But in stable angina, we have no elevation of troponin levels because we don't have the death of those cells. There's just ischemia occurring, okay? There's no infarction, right? There's no complete blockage, and there's no usual ECG changes, okay? So overall, stable angina, what you need to know is that if there's a stenosis greater than 70, then it can cause stable angina, and all it is just pain on exertion, okay? And we can treat that or resolve it with nitroglycerins, okay? So any nitrate help or rest is going to help alleviate our stable angina, okay? Now, as we move forward, we can get unstable angina, okay? So as the occlusion starts to grow, it can, start to, once again, that plaque can dislodge and it can form a thrombosis. And the thrombosis, right, can cause complete occlusion of that coronary artery, or it could travel downstream, become an emboli, and then block the smaller vessels, leading to more severe ischemic episodes, okay? And then this is where we're gonna see for unstable angina, both pain on exertion or at rest. Okay, so it can be present both at rest and on exertion. That means that we have unstable angina. There's still no elevation of troponin levels because we still haven't reached a myocardial infarction, right? We haven't had any dead tissue, but so that means that there's no troponin levels and there's no infarct, but you can see a possible ST depression on EKG changes, but don't look too much into it. What I want you to know right now is stable angina is only pain on exertion with 70% occlusion, and then unstable angina is full occlusion, no infarct, but they still have that pain with mild exertion or even at rest, okay? Even though there's no infarct, and all troponin levels are the same for both anginas, okay? Now, the last angina that we need to talk about is vasospastic. It's also known as presmental, which you'll see, but all this is, and vasospastic is a really great way of kind of defining it, because all it is just the coronary arteries are spasming, okay? And it's going to occur at rest, secondary to that spasm. But what you're going to see is a large risk factor associated with tobacco smoking and cocaine usage, okay? Now, the patient will most likely present at night, so this will occur usually at nighttime, and the angina, the vasospastic angina, will only last 10 to 15 minutes, Okay, it has nothing to do with exertion or non-exertion or rest or non-exertion, right? It only lasts like 10 to 15 minutes or less. If you see that, severe chest pain, angina-like, that is occurring at night and that's lasting at like no longer than 15 minutes, 10 to 15 minutes, then start thinking about vasospastic. And they like to ask about the pathophysiology behind vasospastic angina. And all that it is just hyperactivity of vascular smooth muscle that's causing that vasospasm, okay, within the coronary arteries. All right, so once again, that trigger can include cocaine or tobacco usage, and we're going to treat with calcium channel blockers, nitrates, or smoking cessation, okay? But really not that important. You just have to be able to look and find what vasospastic angina is, and that 10 to 15 minute thing should really, really help you. And lastly, you should probably avoid propranolol, okay, a beta blocker, when having vasospastic angina as well, all right? Now, next, we've covered angina, right? So that's just the chest pain. That's due to ischemic myocardium. We have no infarction yet, right, when we have angina. But what happens when we have a full occlusion now and it leads to an actual infarction? This is when we're going to be starting to see a myocardial infarction. And there's two types. There's NSTEMI and STEMI. And all those stand for is ST elevation MI, that's STEMI, ST elevation MI, myocardial infarction, is STEMI. And then there's non-ST elevation myocardial infarction, which is NSTEMI, okay? That's all that it is. Now, let's talk about the differences between those two. For an NSTEMI, okay, non-ST elevation MI, it's a little bit better, okay? We only have ischemia at the subendocardial space. And the subendocardium of the heart is the area that touches the blood within the heart. So it's closest towards like the chambers, okay? And that's the first to infarct, okay? That's the first area in which we're gonna have ischemia and infarction, okay? Because it has the least amount of blood supply. Now, if we have an NSTEMI, that means it's not a full occlusion. We just have subendocardial ischemia, and we're going to see ST segment depression, okay, on our EKG. Okay, so that's it. Next is STEMI, the ST elevation myocardial infarction. And what we need to know about this, and the difference is that it's not only subendocardial, it's going to be transmural. It's the full thickness of the heart, okay? We have full occlusion, full thickness of the myocardial wall is affected. Okay, and this is where we're going to see the ST segment elevation with pathologic Q waves on our EKG. Okay, and those Q waves are going to be depressed Q waves. That's what I mean when I say pathologic Q waves. Okay, lastly, for both NSTEMI and STEMI, since there is an infarction, right, regardless of the location, right, for NSTEMI, the location of the infarction is subendocardial, and the location of the infarction for STEMI is transmural, the whole entire thickness. Since there is any type of infarction, that means that we're going to be having death of cardiac cells. And since we have death of cardiac cells, that means those are going to be lysing out all their proteins into the environment, into the blood. And so that's why we see elevated troponin levels, because troponin is a protein found in cardiac muscle. Once we have death of those cardiac cells, we're going to have the lysis of all those proteins inside those cells, and you're going to see elevations in the blood of troponin. Okay? So overall, let's just do a quick review of what's going on. First, we have stable angina that's only on exertion. Rest is fine. Nitroglycerin helps treat it. We have no elevation in troponin levels. There's no infarction, and there's no changes in the EKG. Unstable angina, it's present whether you're at rest or on exertion, okay? There's no elevation, though, in troponin levels because there's no infarcts. NSTEMI is present both at rest, right, and on exertion, but we're going to have elevated troponin levels because we have an infarction located at the subendocardial area of the heart, okay? And so what we're going to see on the EKG is ST depression and a T-wave inversion. And lastly is our STEMI, okay, ST elevation myocardial infarction. Once again, you're going to have pain at rest and on exertion, and you're going to have elevated troponin levels due to the fact that there's an infarction that's transmural, the complete full thickness of the myocardial wall. And once again, the EKG is going to show it. It's in the name, an ST elevation. All right? So that's our full overview of what we're going to see with ischemic heart disease and its manifestations. Now, there's a couple other things I'm going to talk about within this chapter real quick. The first one is going to be sudden cardiac death, okay? The question that they like to ask you is, sometimes patients are going to come in, they just have sudden cardiac death. Randomly in their lives, they might not have any other expected cardiac abnormalities, and they just have an unexpected death due to cardiac issues, okay? And the most common cause of this is going to be lethal arrhythmia, ventricular fibrillation, so VFib, all right? So majority of the time, whenever patients die randomly, due to a heart disease, it's going to be VFib as the common cause. The lethal arrhythmia is VFib, okay? And there's two other things that are relatively lower yield. The first thing is chronic ischemic heart disease. You can have myocardial hibernation. And so what happens is that you actually have no ischemia and no death. There's no infarction due to the fact that the left ventricle goes into hibernation and it has a potential to regain all of its ability, okay? So if we have chronic ischemia that lasts for a really, really long time, the heart's gonna be like, okay, I'm used to this, not getting enough oxygen. So I'm gonna wait until someone figures it out, and then once I get cleared and the oxygen comes back to me, then I'll bring my left ventricle back and I can work again. So that's just all it is, myocardial hibernation, okay? In contrast, there's myocardial stunning, and all this is that the left ventricle systolic dysfunction occurs after a brief episode of acute ischemia. Okay, so once brief myocardial stunning, we have a brief episode of ischemia, our left ventricle has dysfunction, but then it comes back after oxygen is supplied. Myocardial hibernation is we've had a long period of ischemia over time, and so that gave us more ability for our left ventricle to realize that there's going to be some dysfunction, and then once we provide oxygen back, it can get fully back. Okay, but those are relatively lower yield. I want you to know fully angina, the NSTEMI, and STEMI. All right.